I would like to invite our speakers and our panelists, who I'm going to introduce now, to come up, and we'll have a little question and answer before we adjourn. I would like to introduce Dr. Mel Chetland, who not only has been a teacher of mine, was chairman of cardiology at Letterman, among many other places. Dr. Gabe Gregoratis was also chairman of cardiology at Letterman. Dr. Joel Carliner was chief of cardiology at the VA Medical Center here in San Francisco. All three have had long, distinguished careers, and if you were going to name the leaders in cardiology in the Bay Area, they would be very high among that list. So I would like to then ask you all to sit down, and I'd like to just ask Gabe and Joel and Mel if you have any comments about where you think auscultation is going, and do you think we'll have a phoenix here rising from the ashes of what was...
Want to go?
Yes.
Yeah, this looks to me to be a very elegant device, and certainly it seems to me that it will have many different applications, both in research, as was shown very nicely in the preceding 3 lectures, but also clinically. Specifically, I think, where I would think for my role, in my role as a teacher, teaching medical students and house staff, I think it would be very important in helping the novice time murmurs and sounds. It has been my experience that the most difficult thing many students have is to time a murmur. Just last week, making rounds with a 4th-year medical student from a very prominent West Coast medical school, she was totally, it was not ours. It was not UCSF. She had ongoing difficulty determining whether a murmur was systolic or diastolic, something very elementary. And something like this would be very helpful. And along those lines, I would encourage the company, since it is in their future plans, to try to introduce the electrocardiographic signal along with the phonocardiographic signal. That would be extremely helpful in terms of timing.
It's a great idea. I've had a prototype with an ECG, and you're absolutely right.
And I must say just one more thing, that I thought I had died and gone back 45 or 50 years, because having trained in the era before echocardiography, this is how we learned physical examination and...
yeah. Well, you know, the repeat of the past isn't always bad. Mel?
Yeah. I have to say that over the last 20 years, I've been giving a standardized auscultation test to medical students, internal medicine residents, and fellows. And I can tell you that my results and the results of other people who have done the same thing in the literature shows basically that we don't teach auscultation very well, or at least people have not learned it very well. For the medical students, their ability to detect the usual heart sounds and murmurs, about 30%. The internal medicine residents get up to 40%, and the fellows get up to 50 to 60%. There is a gradient, but it's not, the slope is very small. If you think about it, or ask your medical students how much formal teaching they've had with auscultation, you'll be shocked to find out that it is extremely small. Not only that, but as an individual progresses through their education, there is always an assumption that the person that you're a mentor for has learned cardiac auscultation. So the medical students get lectures in physical diagnosis. When they're interns, it's assumed that they already know that. And the process of going back when somebody listens to a patient and then having somebody with more experience listen and find that there's either agreement or disagreement, trying to find out what the actual heart sound is, that kind of teaching is not done. And when you get into internal medicine residents and fellows, it's certainly not done. Even when Gabe makes his rounds, sometimes the rounds, he actually goes listen to the patient with the student. But sometimes rounds are made in the hall.
Outside the room.
Pardon me?
Outside the room.
Yeah, outside the room. So coming back to this equipment, anything that focuses on auscultation, anything that focuses on trying to make the physician a better physician is going to be valuable. And certainly being able to watch the photocardiogram as you listen will make it more likely that you will be focusing on what you're hearing and what the sounds that you're hearing actually mean, what they're physiologically related and pathophysiologically related to. So I think it's going to be very good for teaching.
So perhaps a renaissance. Joel?
Well, I agree with everything the previous two speakers said. I'd just like to raise one other issue that occurred to me, and that is be careful what you wish for. The last speaker on at the podium mentioned that he gets what you get an email every 3 months. Is that right? Telling you how many echoes you've ordered, or over order, or whatever. Whoever makes that decision. Well, if you're going to follow patients, for example, with aortic stenosis, the question is how often are you going to get this test on them? And then if you find out that, in fact, it looks like they've lost one of the A components, you're going to do a further workup, and I think you're going to wind up with doing more operations, whether they're TAVR or conventional valve replacement, and increase the cost of medical care. So then they'll be after you for that. So I think that as more sophisticated diagnosis becomes available, which this represents, there is a risk that we'll get too good at what we're doing, intervene earlier, and drive up the cost of medical care. And then they'll come back 10 years from now and say, look what you guys have done.
Or we'll drive it down. So
I have...
yeah, go ahead.
Yeah, I have just a couple of very minor concerns regarding this instrument. I have not used it, of course, but the quality of the murmurs that came over the PA system was very unnatural to my ear. I don't know if that is a function of the amplification in the speakers or what. And that, if that is the real quality of sounds that comes through, and Nelson, you can answer that.
No.
All right.
The murmurs sound like the murmurs when you use the device. Those were simulators, I think. I think those came from that guy back there with a shirt on. Yeah, oh, okay. But the actual sounds are quite natural.
So my other concern is even minor, more minor than the first. Using the term dynamic auscultation, you know, we have used the term dynamic auscultation for many years when we use some type of pharmacodynamic intervention to augment or reduce the intensity of a murmur. So I don't know if using this instrument falls in that category, or perhaps using another term like extended auscultation, assisted auscultation, whatever.
Be like assisted living.
Yeah, like assisted. That fits in with my early bird special habits.
I'd like to ask a question about the magnitude of the phonocardiographic deflections, because the gain, obviously, as you increase the gain, you're going to increase the magnitude.
Mm-hmm.
And although that might not influence a ratio between two hard sounds, it certainly makes a problem if you're measuring the height of a hard sound or height of a deflection.
Mm-hmm.
So there must be some way to standardize.
Yeah,
that.
the thing I've asked them to develop as a software upgrade to any instrument that's out there is a sort of I button that gives you an ideal setting, you know, time and time again, because there are many variables here, and that's something that it's taken me a while to learn to control, and I think that could be done automatically.
Mm-hmm.
Yeah.
How about, do you signal average to get rid of the ambient?
No, not now. But I think there are probably algorithms that do, but I've been a little lazy about recording things. I've just jumped right in and listened the way I always did, you know.
Yes,
Arvin, I have a question for you. Mike Wren, and Mike Wren as well, one of our core fellows who was kind enough to come tonight, Gabe Brooks, found those articles that you were referring to about the frequency content of aortic stenosis murmurs that was in an IEEE journal, and so unlikely to have ever been seen by human eyes. But he, do you think, have you had a chance to look those over, and do you think that's a different direction, or is it pretty much the same thing you've been doing?
Yes, in fact.
Would you speak in the microphone?
Sure. So we have actually taken samples of various grades of aortic stenosis, like mild, moderate, severe, and we definitely find differences in the frequency characteristics. So we believe we can actually build algorithms to actually differentiate them, and that's where our first focus is to efficiently separate the systole and diastole. And once we do that, in terms of the grading of the murmur, both in terms of frequency as well as amplitude, definitely we can actually differentiate that. So we are actually exactly going in that same direction.
Okay. Samir, any further comments you'd like to make about some of the other things that we were discussing, or?
No, I mean, I think a lot of it's been said in terms of the device being a real opportunity to, for example, you know, with the pulmonary hypertension patients, really capture the intensity of P2 and guide therapy, and I think there's a lot of there could be a lot of excitement there. But again, the challenge is really how do you get rid of the noise? How do you apply the microphone to the chest? And I think that's something that really, especially with this device, with everything connected together, holding it appropriately to reduce the noise. And I think that's one of the challenges that we need to all kind of work on and think about.
Yes, I just want to make a little comment about Dr. Chillin's suggestion about correlating PR interval with S1, S2 ratio. I guess partly because of our small sample size, we actually did look at the correlation, and actually it was not significant. But it doesn't mean there was not a a correlation. We clearly know by physiology, those two factors do clearly, affect, have correlation. So we think the reason that our S1 did not correlate with PR interval is probably because we didn't have extreme values of PR interval, and also I guess the S1. We only corrected the S1 with S2. There are probably other factors that affected S1 amplitude that we think, yeah.
The PR affect S1 won't affect S2. So if you've got somebody, let's say,
Speak in the microphone.
if you've got somebody with good left ventricular function, good DPT,
Right.
and a long PR interval, your first heart sound will be decreased.
Right.
and your ratio will be, will say that this correlates with poor DPDT when it doesn't.
Right.
That's why I suggested that you look at that in those instances where it doesn't correlate.
Right. So we have to control the left ventricular function and compare just the PR interval. Because we didn't look at that. And also, the other comment I want to make is we actually do compare the group with normal and abnormal left ventricular systolic function, and the PR intervals actually between the two groups actually are not significantly different. So in terms of the amplitude difference between the two groups in our study, we know that the PR interval wasn't a significant contribution. It was most, as I said, as many factors as we could correct, it was most likely the left ventricular systolic dysfunction that account for the difference. Yeah. So thank you.
Okay. If there are any questions from the audience, a good time to bring them up now. We're unlikely to have this much concentrated phono expertise, if you will, gathered in one spot. So if there's any questions that have occurred to you all. Yes?
You mentioned the PR interval. Would atrial
Yes.
enlargement mean anything?
Yes, I think it would, in the sense that atrial suction has something to do with closing the mitral valve. So if the atrium is defective, that might slow that. I'm not sure what it would do exactly. That would merit study. I don't know if I can answer.
Excluded those people.
No, I don't know.
No.
I mean, everybody, I don't think we did. Atrial failure, primary atrial failure is pretty unusual, though. I mean, looking at P waves, most people have pretty good size. I don't think so.
If you listen carefully to people with atrial fibrillation and focus on the first heart sound, it varies in intensity depending on what the position of the valve is at the time of ventricular contraction.
Of course, that's no P wave at all. Yeah. Ted. A question on what patterns?
Another panel.
Oh, yes.
What would it take for the professional society to revise the guidelines to include auscultation?
It would take a substantial body of literature. Just like everything else. Although I would say one thing about that, it turns out that an awful lot of things in guidelines is not supported. We learned that in Grand Rounds the other day from Rob Califf, who presented some data on that. Well, I would imagine a substantial number of people writing guidelines would need to be users and believers, and then they would write it in.
I think more than guidelines, what we need to focus on is universities and medical schools in the teaching. I think that's, if we're going to revive the importance of auscultation, is a very basic skill for any physician, not just cardiologist. It will have to start at the university level.
I totally agree. You have to change the habits of people that are nascent, that are in their early stages, and then they carry that through their careers. It's a little harder to teach the, shall we say, the seasoned canine new tricks. I think though people who've been around the block a little bit do welcome an addition to their abilities as well. So I don't think at that end it's also promising. I do think it is. Any other last words? We have reached our maximum hospital benefit.
I have a last word.
Oh, good.
No, I would like to commend you, Nelson, and your co-investigators for taking the bull by the horn, so to speak, and resurrecting the art of phonocardiography and showing how important information can be gotten out of it with relatively simple means.
Thank you. Thank you, and thank you everybody for coming.